గుడ్ మార్నింగ్ ఫ్రెండ్స్. ఐఎంఏ ఇండియన్ మెడికల్ అసోసియేషన్ సంబంధించి 3వ రోజు చివరి రోజు సదస్సు జరగబోతోంది. 2 రోజుల పాటు సుదీర్ఘంగా ఈ సీజనల్ డిసీజ్ దగ్గర నుంచి సివియర్ డిసీజ్ దగ్గర, అంటే సీజనల్గా వచ్చే వ్యాధుల దగ్గర నుంచి సివియర్గా ఉండే వ్యాధులు ఏవైతున్నాయో, దీర్ఘకాలిక వ్యాధులు ఏవైతున్నాయో అలాంటి వ్యాధుల గురించి ఎక్స్ప్లెయిన్ చేయడం, వాటి అధ్యయనం, తర్వాత వాటి నివారణ, వీటన్నిటి మీద విశ్లేషణాత్మకంగా సీనియర్ మోస్ట్ టాప్ మోస్ట్ డాక్టర్స్, ఏపీలో ఉన్న టాప్ మోస్ట్ డాక్టర్స్ విశ్లేషించడం మనం చూసాం. అంటే ఎక్కువ మంది ఎందుకో మిగతా వాటికి చూపినంత ఇంట్రెస్ట్ మెడికల్ సంబంధించి చూపట్లేదు. మరి అఫ్కోర్స్ చాలామందికి బోరింగ్ సబ్జెక్ట్ అనుకుంటారేమో. నిజంగా భవిష్యత్తులో రోగాల బారిన పడకుండా, రోగాల బారిన ముందస్తు ప్రిస్క్రిప్షన్స్ ఏమైతే తీసుకుంటామో, అలాగే వచ్చిన తర్వాత వాటి నుంచి మనం ఎలా విముక్తి పొందాలని ఆలోచిస్తామో, రాకూడదు అనుకుంటాం, వస్తాయి. వచ్చిన తర్వాత మనం తీసుకోవాల్సిన జాగ్రత్తలు ఉంటాయి. విసిగి వేసారిపోయి దీర్ఘకాలిక వ్యాధులతోటి విసిగి వేసారిపోతూ ఉంటాం. వాటిని ఎలా విముక్తి పొందాలి, రిలీఫ్ పొందాలి. విముక్తి పొందేది వేరు, రిలీఫ్ పొందేది వేరు. విసిగి వేసారిపోయే వాళ్ళు ఫస్ట్ రిలీఫ్ కోరుకుంటారు, తర్వాత విముక్తి కోరుకుంటారు. వీటి అన్నిటికీ పరిష్కార మార్గాలు అధ్యయనం చేస్తేనే దొరుకుతాయి. టాప్ మోస్ట్ డాక్టర్స్ మన ఇండియాలోనే టాప్ మోస్ట్ డాక్టర్స్ ఎంతమంది ఉన్నారు, మన ఆంధ్రప్రదేశ్లో అలాంటి టాప్ మోస్ట్ డాక్టర్స్ చాలామంది ఉన్నారు. అలా టాప్ మోస్ట్ డాక్టర్స్ ఒక మంచి సలహా సూచనలు ఇచ్చినప్పుడు దాన్ని సీరియస్గా తీసుకుంటే నిజంగా మంచి ఫలితాలే వస్తాయి. ఎందుకో ఆశించిన స్థాయిలో స్పందించరు. మన వాళ్ళు కొన్నిటి మీద దృష్టి పెడతారు తప్పితే మంచి టాపిక్ మీద దృష్టి పెట్టట్లేదు. ఒక గంట పాటు పూర్తిగా మంచి కార్యక్రమాల మీద దృష్టి పెట్టి చక్కగా వింటే, వారు డాక్టర్స్ ఇచ్చే సలహాలు సూచనలను పాటిస్తే చాలా వరకు మనం ఆదిలోనే రోగాల బారి నుంచి విముక్తి పొందొచ్చు. డాక్టర్ చెప్తుంటే నిజంగా చాలా రిలీఫ్ అనిపిస్తుంది. పూర్తి అయితే సబ్జెక్ట్ పూర్తిగా వినాలి. సాక్ష్యాలతో సహా మంచి సలహాలు సూచనలు, మంచి గైడెన్స్ ఇస్తున్నారు. ఒక అద్భుతమైన, నిజంగా మంచి అద్భుతమైన కార్యక్రమం అన్నమాట. అలాంటి అద్భుతమైన కార్యక్రమానికి ఆశించిన స్థాయిలో స్పందన లేకపోవడమే బాధాకరం. ఎనీహౌ, సండే 1 గంట పాటు లైవ్ మీకు స్పష్టంగా అక్కడ జరుగుతున్న కార్యక్రమాలన్నీ లైవ్ చూపిస్తాను. 1 గంట పాటు మీరు చూడండి. డెఫినెట్గా ఎంతో కొంత ఉపయోగపడుతుంది ఆ కార్యక్రమం. మనకు దగ్గరలో ఉన్నాం. ఈరోజు చివరి రోజు కాబట్టి చాలా ముఖ్యమైన రోజు అని చెప్పాలి. ఇప్పుడు మనం డాక్టర్లు, ఇప్పుడు మనం అక్కడికి వస్తున్న డాక్టర్లని మనం స్వయంగా మామూలుగా కలవాలి అంటే వాళ్ళకి అపాయింట్మెంట్స్ దొరకడం కూడా మనకి చాలా కష్టం. అలాంటి డాక్టర్స్ మనకు స్వయంగా వచ్చి వాళ్ళు గైడెన్స్ ఇస్తున్నారంటే వాటిని ఉపయోగించుకుందాం. మంచి కార్యక్రమం. మనం వినడం, 10 మందికి ఆ సబ్జెక్ట్ని కూడా షేర్ చేయడం కూడా, అంటే చాలా సరళమైన పద్ధతిలో ఎక్స్ప్లెయిన్ చేస్తున్నారు. మనకి చాలా ఇంట్రెస్టింగ్గా ఉంటుంది టాపిక్. ముందు వినడం ప్రారంభించాలి. వినడం ప్రారంభిస్తే టాపిక్ ఆటోమేటిక్గా మనకి ఇంట్రెస్ట్ కలుగుతుంది. దీర్ఘకాలిక వ్యాధులతో బాధపడుతున్న రోగులు చూస్తున్నాం కదా. పక్క కంటిన్యూగా మందులు వేసుకోవడం ఒక సమస్య అయితే, ఆ మందుల వల్ల వచ్చే ఇన్ఫెక్షన్స్, సైడ్ ఎఫెక్ట్స్ ఇవన్నీ ఎంత ప్రమాదకర స్థాయిలో ఉన్నాయో మనం చూస్తూ ఉన్నాం. ఒక్క గంట పాటు మనం వింటే చాలా చాలా వరకు పరిష్కారాలు దొరుకుతాయి. నాగేష్ గారు హాయ్ అండి. గుంటూరు మెడికల్ కాలేజ్ అండి, మేము ఇప్పుడు దగ్గరలోనే ఉన్నాం. జింకానా స్టేడియంలో జరుగుతున్నాయి 3 రోజులుగా. ఇది ఈరోజు 3వ రోజు. అందరూ కూడా ఎయిమ్స్ టాప్ మోస్ట్ డాక్టర్స్, టాప్ మోస్ట్ గుంటూరు మన ఆంధ్రప్రదేశ్లో ఉన్న ఫేమస్ డాక్టర్స్ అందరూ, ఏపీ తెలంగాణ 2 రాష్ట్రాల నుంచి డాక్టర్స్ సదస్సులు అటెండ్ అవుతున్నారు. వారు సెమినార్లో వారు సలహాలు సూచనలు వండర్ఫుల్ అనమాట. నిజంగా చెప్పాలంటే ప్రాక్టికల్గా మనకి ప్రజెంటేషన్ కూడా ప్రజెంటేషన్ అద్భుతంగా ప్రజెంటేషన్ చేస్తున్నారు. ఒక గంట పాటు చూడండి, డెఫినెట్గా ఉపయోగపడుతుంది. అసలు సబ్జెక్ట్ అయితే 100% ఉపయోగపడుతుంది. మనకు తెలియకుండానే ఏదైనా ఒక డిసీజ్ వచ్చినప్పుడు ఫస్ట్ ఎయిడ్ మనం ఎలా చేసుకోవాలి అనేది మనం డాక్టర్ దగ్గరికి వెళ్ళకుండానే వాళ్ళ మాటలు వింటే మనకి చాలా క్లారిటీ వస్తుంది అన్నమాట. సో అలాంటి అద్భుతమైన అవకాశం మనకి ఇది 66వ రాష్ట్ర సదస్సు 16 సంవత్సరాల తర్వాత గుంటూరులో జరుగుతుంది అన్నమాట. ఇండియన్ మెడికల్ అసోసియేషన్ ఆధ్వర్యంలో జరుగుతుంది ఈ కార్యక్రమం. వాళ్ళు ఒక్కొక్క టాపిక్ గురించి ఎక్స్ప్లెయిన్ చేస్తుంటే దాని వెనక వాళ్ళు గ్రౌండ్ వర్క్ ఎంత వర్క్ చేశారనేది మనకు అర్థమవుతుంటుంది అన్నమాట. సబ్జెక్ట్ గురించి అనలైజ్ చేయడం, ఆ టాపిక్ ఈజీ పద్ధతిలో మనకు అర్థమయ్యే రీతిలో సరళంగా ఉంటుంది. చాలా బాగుంది, మంచి టాపిక్. నిన్న షుగర్ గురించి ఎక్స్ప్లెయిన్ చేశారు, అసలు అమేజింగ్ అని చెప్పచ్చు. అలాగే చర్మ వ్యాధులు, వాళ్ళు ఎన్నో అధ్యయనాలు చేసి వాటికి సంబంధించిన రీసెర్చ్ కంప్లీట్ చేసిన తర్వాత బుక్స్ రిలీజ్ చేశారు. తర్వాత వాటి మీద పరీక్షలు నిర్వహించిన తర్వాత వచ్చిన రిజల్ట్ ఎలా ఉంది, దేశవ్యాప్తంగా రిజల్ట్ ఎలా ఉంది, మన ఏపీలో రిజల్ట్ ఎలా ఉంది, కొత్తగా కనుగొన్న మెడిసిన్స్ సంబంధించి కానీ అసలు ముందు జబ్బు రాకుండా ఉండాలి అంటే మనం ఎలాంటి చర్యలు చేపట్టాలో చెప్తారు. తర్వాత జబ్బు తప్పని పరిస్థితుల్లో జబ్బు వస్తే ఆ జబ్బు నుంచి మనం ఎలా రిలీఫ్ పొందాలో ఇలాంటి సెమినార్లకి మనం ₹1000 ఖర్చు పెట్టి వెళ్ళాల్సి ఉంటుంది. మామూలుగా అయితే మనకి ఫ్రీగా, అంటే యాక్చువల్గా ఓన్లీ డాక్టర్స్ రివ్యూ చేసుకోవడానికి ఈ కార్యక్రమాలు. డాక్టర్స్ 2 తెలుగు రాష్ట్రాల్లో దాదాపు 2500 మందికి పైగా రిజిస్ట్రేషన్ జరిగినాయని చెప్తున్నారు. 2500 మంది డాక్టర్స్ ఒక వేదిక మీదకి వచ్చి వాళ్ళు చేస్తున్న సేవల గురించి కొత్తగా వస్తున్న టెక్నాలజీ గురించి వాళ్ళు ఎక్స్ప్లెయిన్ చేస్తూ ఉంటే, అలాంటి వేదిక మనకి ఫ్రీ స్పేస్, ఒక్క పైసా కూడా ఖర్చు లేకుండా ఉచితంగా చూపిస్తున్నాం. లైవ్ కార్యక్రమం మన అలా ఆంధ్రప్రదేశ్ ద్వారా. దేంట్లో రాదు, ఓన్లీ మన అలా ఆంధ్రప్రదేశ్లోనే అనేక కార్యక్రమాలకు సంబంధించి చూపించారు చాలా ఈ 2 days నుంచి. సో డెఫినెట్గా ఉపయోగపడుతుంది. ఇది ఎప్పుడు ఉపయోగపడుతుంది అంటే ఇప్పుడు వినడం వెంటనే ఉపయోగపడకపోవచ్చు. మనకేదైనా హెల్త్ ప్రాబ్లమ్స్ వచ్చినప్పుడు ఒక్కసారి మన వీడియో ఓపెన్ చేస్తే 100% మనకి రిజల్ట్ వస్తుంది. 100%. దగ్గరకు వచ్చేసా, ఒక 2-3 మినిట్స్లో వెళ్ళిపోతాం అక్కడికి. సాధ్యమైనంత వరకు లైవ్ మిస్ కాకుండా చూడండి. డెఫినెట్గా సబ్జెక్ట్ అందరికి ఉపయోగపడుతుంది. రెండు రోజుల పాటు చాలా విశ్లేషణాత్మకంగా, చాలా వివరణాత్మకంగా సీనియర్ మోస్ట్ డాక్టర్స్ వాళ్ళ అనుభవాలు, వాళ్ళు చేసిన రీసెర్చ్, తర్వాత వచ్చిన ఫలితాలు, ఇవన్నీ చాలా చాలా ఎక్సలెంట్గా ఎక్స్ప్లెయిన్ చేశారు. దానికి సంబంధించిన వీడియోస్ మన ఛానల్లో ఉన్నాయి. లైవ్ చేసాము, ప్లస్ మామూలు జనరల్ వీడియోస్ కూడా అప్లోడ్ చేసాము. జింకా ఆడిటోరియం అనమాట, గుంటూరు మెడికల్ కాలేజీకి సంబంధించిన జింకా ఆడిటోరియం చాలా అద్భుతంగా ఉంటుంది. పరిసరాలు కూడా లక్షల రూపాయలు ఖర్చు పెట్టి వేదిక, ఎంత భారీ స్థాయిలో వేదిక ఏర్పాటు చేసి 2500 మంది డాక్టర్లు ఒకే వేదిక ఉపయోగించి మనకి ఈ కార్యక్రమం ఏర్పాటు చేశారు. చూస్తున్నారు కదా, రెండు రోజుల పాటు 9కి ఎగ్జాక్ట్ 9కి స్టార్ట్ అయింది ప్రోగ్రాము. ఈరోజు సండే కదా, కొంచెం విరామం, రిలాక్స్గా వస్తున్నట్టున్నారు. ఈరోజు లాస్ట్ డే ప్రోగ్రామ్. ఇది లాస్ట్ డే ప్రోగ్రామ్ షెడ్యూల్ చూడండి ఇక్కడ. లేట్ అయింది కాబట్టి మనం డైరెక్ట్గా ప్రోగ్రామ్కి వెళ్దాం.
Addiction is the one thing which can cause this to happen.
మంచి కార్యక్రమం, ఇలాంటి కార్యక్రమాలను మిస్ చేసుకుంటాం. వెళ్ళొచ్చు సార్, లోపలికి వెళ్ళాలా? తీసుకోండి, లాక్ చేసి ఒకసారి లాక్ చేసి
Patient is forming a stone, right? Through infection, it is a stoic stone, calcium, the triphosphate stones. Then our main aim is to see the ureteric colic, how it's being managed. The ureteric stones will be formed only in the kidneys, not in the ureter. So the same composition of the stones will be there, and the stones, when they are coming down, then only they produce the breed. So once it is coming down, it may be obstructed in three places, mainly at the PUJ, at the crossing of the vessel, and third is at the U junction. These are the narrowest points where you can the stone can impact. Why? So the ureter is divided into three segments. Then radiologically and anatomically. From PUJ to upper border of the sacrum, this is the upper ureter. The segment lying on the SI joint is the mid ureter. If it is below the SI joint, that is the lower ureter. This is very important because some of the urologists, some of the radiologists, and some of the people reporting as a mid-ureteric stone and an upper ureteric stone as a mid-ureteric stone, and mid-ureteric stone as the lower ureteric stone, something like that. This frequently happens. Why it is important is, suppose if you are not seeing, and because some of the urologists go to different places, thinking that
camera effect just
they say, maybe saying that the mid-ureteric stone, once you are not equipped and you are not willing with the management of the upper ureter, sometimes you have to do other procedures rather than ureteroscopy, you have to do a piecing. If you are not done, prepared with that, you are likely to get into trouble. So this is the radiological anatomy. That is the upper ureter from PUJ to upper part of the sacrum, and the sacrum to the mid ureter, and this is the lower ureter. So these are the symptoms. If the patient is having serious line to grind is the commonest symptom. Sometimes they may get abdominal bloating, vomiting sensation, fever. Sometimes they may feel things, And some of the times, that one of the very sometimes the patient complains of only testicular pain, and people get a scrotal scan done, but the stone is impacted in the lower ureter, can give rise to pain only in the testis without any symptoms. Sometimes if you are seeing testis is normal, an ultrasound and clinical examination, please try to do an ultrasound scan of the abdomen, and sometimes you may have to do a CT scan, where the ultrasound scan of the abdomen also may not reveal the stone because there is no hydronephrosis. That is one of the thing. And the people sometimes they want to pass motion so many times. That is also an indicator of ureteric stone. So these are the differential diagnosis, appendicitis, and previously when scans and other things are not available, and that is a common thing which they used to do appendicectomy for right ureteric colic, and ovarian cyst, and mesenteric adenitis, and ruptured ectopic, and tuber. These are the things which you can differentiate with all the sophisticated latest investigations. So in this, whatever Practical points are mainly what are the diagnostic evaluation, history, physical examination, and the X-ray KV. X-ray KV is not actually a specific or definite diagnostic test. Previously, it used to be available. Only used to do X-ray. You can miss. Only you can diagnose only 30% of the cases. In 70% of the cases, they generally missed on the X-ray KV. That's what I will tell you. That patient, you remember, just before removing the stent, I did an ultrasound, CT scan, X-ray, it revealed. So X-ray KV is sometimes useful, not many times. Intravenous spelography is outdated. Ultrasound abdomen is and pelvis is the standard first test you have to do. And CCT KV is the gold standard, you know that. But there are things which have to be careful. All these stone patients, they are likely to get recurrence in 5 to 10 years. How much of radiation we are subjecting the patient? It is almost 10 millisieverts, MSV. So, normal radiation in X-ray is 0.7. That means you are exposing the patient to almost 10 times the radiation. If the patient has to undergo surgery, then he has to still undergo some of the radiation exposure is some of the problem. And the patient is not able to diagnose and if not managed properly, if you have to do a repeat CT scan, then you are subjecting the patient again. So how much of radiation? Almost 20-25 millisieverts he is getting exposed. And that is the hazard we are giving to the patient unnecessary. So my strategy is only do an ultrasound. If the patient is not having many symptoms, other things are stable, do an ultrasound and we can avoid CT scan. If the patient is having a little big stone, he has to need some other complication, then I subject the patient for CT scan only. So like that you can spare some of the patient from exposure, especially females and the children. Management aspect, this is the thing you are not able to see, but the main cause is spasm and other things, the prostaglandin secretion. Because of that, the pain occurs. So what we are giving, suppose indications for conservative management is if it is less than 5 mm stone or around 5 mm stone, and the stone is in the lower third of the ureter is undilated, and though there is no fever and other things, you can manage them conservatively even if the patient is having pain. Only one thing I want to stress, if the patient is not having fever, don't give antibiotics. This is the one thing that I want to stress in this lecture. Elevated total count is not indication to give antibiotics. That you have to remember. And unfortunately, that is what is happening to most of the patients. Everybody gives some antibiotic with pain relieving agents. That is the most unfortunate thing. Please, my request is not to give any antibiotic if the patient is not having any fever and other problems. So medical management is NSAIDs are the choice. That means aceclofenac and diclofenac. This is the first drugs you have to give. You need not give any antispasmodics. Antispasmodics have no role. Then, if the patient and opioids also can be given, but there are side effects because of that. So the first choice is give only, some people give buscopan, something like the protein. This is not going to be effective in this. You have to give only NSAIDs, but these are not suitable. Sometimes you can give paracetamol IV in the children and pregnant ladies. So antispasmodic have no role. Medical expressive therapy, there are 3 drugs which can facilitate the passage of the stone, like alpha blockers and calcium channel blockers and steroids. You can add steroids and alpha blockers. So in this, most of the practitioners, what I observed is giving alpha blockers with the dutasteroid. So Urimax D, something like that. What is the need of dutasteroid in those cases? You don't know. So I understand the pathology. There is only the alpha-1 receptors are there in the lower end of the ureter and the proximal urethra. Then if you give only alpha blockers, it relaxes the muscle and it facilitates the passage of the stone. Like that, steroids can decrease the inflammation and it facilitates the passage of the stone. So this is the basis of the medical experts therapy, and there is a statistic that 30 or 40% the passage is more when compared to standard treatment. So less than 5%, suppose 5 millimeter stone, there is a chance of 90% passage of the stone, and if it is more than 8 millimeters, then sometimes you may have to intervene. The mechanism, so this is the mechanism of action I told you already. Surgeries, what we can do is, it depends upon the stone and location. Upper ureter, we do a PCNL, GSWL, or RIRS, retrograde intrarenal surgery, and ESWL is one safest thing for the patients, which is a relatively smooth stone, a soft stone. In this, lasers are not used, and sometimes the people think that the lasers are used in ESWL. ESWL don't require any lasers. Next thing is RIRS, retrograde intrarenal surgery, where we pass flexible ureteroscope from below and we break the stone. That is one of the where you can reach any calcium system. That is one thing. And ureteroscopy, you can manage, rigid ureteroscopy you can manage for the lower ureteric stones. Surgery, that this is the RIRS or PCNL, ERS for the upper ureteric stones, ESWL, and mid-ureter ERSL and RIRS, lower ureter only ERSL. Sometimes large stones may require laparoscopy surgery. Dietary recommendations, this is also one of the common mistakes we see. We always try to restrict the calcium. Don't restrict the calcium. If you are restricting the calcium, you are doing more harm to the patient. And giving supplements sometimes can be avoided, but the calcium citrate is one of the safest drugs which you can give as a supplement, because it is proven that calcium, it will not increase the calcium level. So if you are restricting the calcium, you are doing more damage to the patient. Dietary restriction, sodium you can restrict, protein you can restrict, and we advise them to have more water intake. That's the thing. Don't restrict the calcium. That is. So dose. What I want to convey is, don't give antibiotics for unnecessary in the asymptomatic patients or when there is no fever and other things. And don't give hydrotherapy, just giving fluids by the RMPs and they thinking that they can pass the stone. This is not advisable. And antispasmodics have no role. Mainly thing is, you have to do active intervention. So this is also very important. The patient is having fever, the patient is having upper ureteric stone, if the patient is going into sepsis. Don't try bilateral stones. Don't try to treat them conservatively. This is what is happening for a general practitioner or some other specialist. Even if they see 1.2 centimeter stone in the upper ureter, they just tell them, oh, it will pass, you can pass, it will dissolve, something like that they tell, unnecessarily wasting the time. And don't put the patient into trouble. If you are having a patient is having sepsis, diabetes, and large stone, this has to be managed very judicially. Bilateral stones is an emergency in most of the cases. You remember all this? With this, I end my talk. Thank you.
Thank you very much, Dr. Viseswarao. Please hold on. Any questions from the floor?
Alkalinization. That's what potassium citrate is the solution which you have to give. You don't add any sodium. That is the thing. And for uric acid stones, it is advisable. And some of the other treatments are available. Suppose calcium hypercalciuria, you can add some of the thiazide drugs like that. And some of the drugs, mainly the uric acid, you can reduce the uric acid level and you can give alkalinization. And most of the people prescribe sodium citrates. These are not advisable.
Many ask us how much fluid we should take. What will you advise? Many ask us how much liquid or water we should drink.
Water, it depends upon the patient profession. If the patient is sitting in the ICU room, just more than at least 1 liter more than what they are taking. That means if they are tolerating about 2 liters, another 3 liters. If it is Suppose if they don't have any other problem like CCF or CKD, they can have the water at least 1 liter more than the required. That is the current stone problem.
Thank you.
Sir, you need to restrict non-vegetarian diet during the urinary pain period, sir.
That's what. IV fluids if you are giving, you are producing more pain during cooling. So that means the more distension of the ureter occurs and more capsule distension, it produces more pain. So as far as possible, don't give hydrate too much of hydration is not necessary in severe colics. The patient is not having pain only, they can take.
So usually in the consumption of non-vegetarian or more protein diet causes urinary output, less urinary output. What do you do on that way?
That's what. Urinary output should be maintained around 2 liters. That's the main aim. Minimum is 1500 per day, up to 2 liters. And we have to be careful in giving more water at one time. If the patient has a heart problem, if the patient is a CKD patient, these people, you have to be very careful.
Thank you, sir.
Right.
Thank you, sir.
Thank you very much, sir. Now I would like to call upon Dr. Naresh Babu Garu, orthopedician. Over to the chairperson, sir, for introducing Dr. Naresh.
Distinguished guest speakers and delegates, very good morning to all. Today's the last topic of this morning session is from a young, dynamic son of the soil, Dr. Naresh Babu. His basic education is from this very medical college, Guntur Medical College. I noticed in the voucher that many of the guest speakers are from college. We are proud of that. Dr. Naresh Babu, after his primary education, he went on to become a fellow of the spinal surgeons, and he started in a big way spinal instrumentation in this region and popularized it. Apart from that, his main another amazing asset is his interest in research activities. He has a meticulous observation, documentation, presentation at various national and international fora, and also he shown how much one can achieve, and also tactfully he got so many funds also, and every one of us, especially youngsters, we have to learn a lot from him. Today's topic, facts and myths about backache. Over to Naresh Babu.
Thank you, sir. Thank you for those kind words. At the outset, I would like to thank IMA for giving me this opportunity. Respected seniors and my teachers, colleagues and friends. So, topic given to me is back pain, the myths and facts of back pain and the insights for primary care. It is such a painful task to listen to back pain early in the morning on Sunday, sitting for 20 minutes. I try to make it simple and try to get some few insights which we can get out of the back pain. So the most common complaint other than cold and fever, after cold and fever, visiting a primary physician is back pain. Be it related to back or not related to back, it is something around the back. And this most common cause for the work absenteeism also. The most common cause for absenteeism of the work is also back pain. And it's such a disabling thing that we may not be able to perform the regular activities with pain. But it ranges from so simple to very devastating conditions. We try to make it very simple and try to understand and analyze this back pain. Once a patient visits your clinic, how we classify these back pains into 4 simple things. So back pain which is coming out of the mechanical thing, which is very common thing. 90% of our regular consultations are only treating this mechanical back pain. That's pain coming out of the fatigue. And second pain is like instability back pain. This is more little bit of a pathology which exists in the spine, which results as a instability pain. And the discogenic pain is the one which is very common, like degeneration of the disc or collapse of the disc related to this. And then the last is the destructive lesions, which is coming out of the infections and tumors. Few things how you can just pick up this pain is mechanical and no need to address this one other than just giving some suggestions and the rest and analysis is that it comes on activity. These patients are fresh in the morning and as the day passes by late evening they feel pain. Whenever they take rest they will be fine and it's completely released with the rest. And they all feel fresh in the mornings and worse in the end of the day. But the discogenic pain is a little different. When there is organic lesion inside the disc, they feel little different compared to these patients. They also have a pain on activity, but they have a specific sitting intolerance. They can't sit long in a fixed position. I think it's very common to many of us. So if you sit without support on the back, when you start noticing the pain, that's where the instability back pain, discogenic back pain you need to suggest. And then the pain which is worse on coughing, sneezing, and the patient wants support to sit either leaning onto the wall or they need a back chair which supports them. And obviously release with the rest. They also feel fresh in the mornings. The main thing which happens is to identify from where the pain is coming from and we need to address these pains. And sometimes the pain can be from the disc or from the root or facet or SI joint. Many of the times none of the above will be the pain or it could be simple colic coming out of the urological problems or gynecological problems in the females or it's abdominal pain referring to the back or all of the above can be associated. And instability is one thing which we need to identify. These patients are very specific. Once you notice these kind of symptoms patients are experiencing, then you need to be very specific on this. They usually happen with lysis, spondylolisthesis, segmental instability. It is also activity related, but the characteristic finding which differentiates this back pain with simple mechanical back pain is they are worse in the mornings. They get up with pain in the bed, so they take some time to get up from the bed. They turn onto the sides and then walk for some time. Once they are fresh and then walk for some time and they get the tone back, the back pain goes off. So early morning pains is the one which we need to give a lot of importance. Those patients who are fresh in the mornings when they are getting up and the activity pain is different from those which comes with that. They feel better with the activity other than the mechanical back pain patients who feel bad with the pain. They feel better with the back pain and then extension, the bending backwards. Those people who used to do the Surya Namaskaras and asanas, they know that when they are trying to bend backwards, they feel pain. So those are the things which we need to be careful. And this causes the reversal of the spinal level. When they try to get up from the sitting, you might be seeing the patients when they're trying to get up from the sitting, they take support of the hands from the chair and they walk few steps bending forwards. After 2-3 steps, they get straightened up and they don't feel pain. The initial getting up from the sitting pain which is worse than getting up from the sitting is again suggests something which is happening under the vertebral instability. Those things are very important which we need to be important. And the worst pain which comes is destructive pain, which is like night pain, happens with the TV spine or tumors and other things which also need to be considered. So how do you treat these patients? 90% of our time in the OPD goes off explaining the patients how to take rest, how to sleep, how to bend forwards, how to lift weights. Should they take rest or should they go back to the work? There are few recommendations. Rest is good for initial 48 hours. Any rest more than 48 hours for any back pain is not going to do good for the patients. It's only going to do wasting on paraspinal muscles. And how to take the bed rest is a very common question, whether you need to have a pillow in the legs or how to sleep. Can they sleep on the floor or they can use these kind of traditional beds or sleeping on the floor. These are all the very, very common complaints, common questions patients ask. The idea is you have to your bed should be just right. What are the patient is a few suggestions. It should be just right. It should not be too soft where the bed bends to the weight, or it should be too firm which causes the pain. It should be just enough. We call them as the unyielding mattresses. The mattress should not be yielding to the body weight. So anything which is 2/3 coir and 1/3 foam is perfect for these patients. So next thing is the famous advertisements which come on the TVs. Oils, massages, So it's very, very, very common. It's every alternate days. It is very potential things. They say Sandhi Sudha oil, which makes your spine better. If it is not reviewed with Sandhi Sudha oil, then you see advanced Sandhi Sudha oil plus, and that gives you pain. These are all very common. Can I use this oil, or can I go for a massage? Can I go for a chiropractor? These are the stone therapies. So back pain is such a vast subject because it responds and resolves on its own. You can try anything available on the earth which is not hurting. So these are the Korean treatments where the patients get treated with the stones. And you know all these funny stones standing on the back and the Ayurvedic things where you make the kati basta things, the oils, medicated oils, all these things work because they all work with the philosophy of manipulation therapy and the heat. But there is a limit to that. Which patient needs what is very important. When the patient is having, this is only good for a mechanical pain, and patients can be, they can get good relief with this, all these symptoms. So this is one new treatment I found out somewhere, I think patients, because he has got shoulder pain, one bandage on the shoulder, right side pain, he had one plaster, on the left side pain, they had another plaster. It's like some kind of a taping which is done under the back. So that is about the conservative management of the back pain, but evaluation part is very, very important. Now that we have, spine is one structure as opposed to the brain and other things in the neurological things which is dynamic. So this needs to have a dynamic evaluation. Whenever we see a patient with the spine, the first thing what we ask is to get an X-ray in the flexion and extension, bending forwards and bending backwards, so that we will find out the lesions. We see MRI like this, but actually all these MRIs are taken when the patient is lying down like that. Even though the MRI looks straight when you read, it is actually not taken when the patient is sitting. It is actually taken when the patient is lying down. So there are a few things which are on loading, which we get missed in these patients. And then there comes the dynamic evaluation of the spine, where we can really understand the thing. So why you are not taking in the standing is a big question. So it is difficult to obtain the images when the patient is in standing, and there are motion artifacts. The patient gets pain when they are standing. But there is revolutionary changes which is happening in the MRI nowadays, and then we can even have a dynamic standing MRI which is mobile loading. You can have an MRI in the sitting, and we can have an MRI in standing. And all these things will reveal exactly what is happening inside the spine. This is the new technology where we are actually able to find out a few of the lesions which are not seen on the patients when they are actually supine. So once the patient sits, patient's complaints also like that. I have pain only on sitting, sir. I have pain only on working onto the desk, but I don't have pain when I am taking rest. But our evaluations mostly happens when the patient is in sitting position. So those cases, we can now evaluate these patients in sitting, and we can have even MRI in the flexion and extension, and you can even get a video of now the MRI. So you are all told that during MRI examination, you are not supposed to move. If you move, you can't get an image. But now the technology has come up to an extent where you can get an MRI in a video format, where you can have actually dynamic flexion and extension and find out what exactly happening to these patients. It becomes very important, and I think sir might be noticing these kind of patients are myelopathic patients. When they come to you, you would definitely know that these patients have got myelopathy. But if you take an MRI examination of these patients, you can see completely almost normal spine, some signal changes. If you subject this patient to the sitting MRI, this is what we are amazed to see such a potential of the dynamic loading. Simple, same patient in supine and sitting, you can see how much difference in the spinal cord compression. And these things can explain exactly what is happening to this patient. So other examples of the same things like progressive myelopathy and sitting flexion and extension, how the buckling of the ligament of arm happens and the stenosis happens. Those patients where there is a missing link between the symptoms and the radiology, there comes the dynamic evaluation of the cervical spine. And even the patient, this patient has been consulting so many times with this acute radiculopathy. But every time I used to treat him only conservatively. There is nothing we can do. We just have to relax because there is no MRI showing nothing. But he insisted to get a sitting MRI. Then we found out there is something prolapsing onto the neck. Now we know that what exactly causes the pain. How you treat that is a different issue. And it also depends on the treatment. Whether you want to operate on these patients, you don't want to operate front or back. It all depends on the So if you have these four MRIs, first one actually requires a conservative treatment, second one is a posterior surgery, and next to anterior combat. This is like a technical things. But actually all these belong to the same patient. Same patient taken in different positions, appearing completely different. So this is taken in supine, this is sitting neutral, sitting flexion, sitting extension. That's where the exact effect of loading is coming back. This work has given us the SRS White Cloud Award, which are quite happy with that. And we can also select the approaches based on that. The same thing can be done for the lumbar spine. When you don't have symptoms which is not correlating and patient has no symptoms in supine and there is only symptoms on standing, you can see how the supine looks on standing, and the traction again it gets relaxed. So these are the new advances which are happening in the evaluation part of the MRI. And these are coming now, more and more surgeries are now being done without operating onto the lamina, removing the lamina on the spine. Those patients, in those categories it comes very handy. So then comes, sir, I'll just quickly go forward, and this is something which is related to the work. So once all these things fails, how do you treat these patients? This is injection techniques which we commonly use in these patients. Epidural steroid is the commonest injection, but the problem with epidural steroid is once you give an injection, it goes all the way and doesn't require the site where exactly need. And this is where we do a selective injection, just positioning the CM. This is majority of our work in day-to-day practice. Those patients who doesn't require surgery, they can easily get treated with pain management, with selective nerve blocks or caudal epidural steroid injections, which gives wonderful results. When everything fails, then we have laminectomies or decompression therapies. You can still do these surgeries with microscope surgeries where with a small opening, you can do from the right side to the left side and over the top decompressions. And the spinal canal decompressions can be now simply done with smaller incisions. And the entire spine can be decompressed from one side to the other side, giving rise to, just need to forward them. So that's how we remove the ligamentum flavum as a bulk and take out the things. Next comes the endoscopic decompressions, where a small hole can be made under the spine and we can completely decompress the nerve roots without opening. So the main worry about the spinal surgery is how much we are actually cutting and devastating. And this is something when you have to have fixations in the spine. So we are all worried how destructive these surgeries are, like you have to open the muscles and cut the bones and remove the ligamentum flavum and fix it. Now, why people avoid spine surgery is because it appears like there is a lot of muscle dissection out of the back. And we might have seen cut is a cut. If it is small or big onto the back, you are permanently disabled. But now those myths are getting broken now. We can do any major surgery with smaller incisions, with avoiding the spine or back surgery. I think now the approach is to approach the spine from the surroundings, not from the center. And the technology has come into such a way that we can just have surgeries. Yeah, 4 moments. Thanks. Now we can have even the screws insertions done percutaneously. You can just have a small stab incision and pass the wires from the percutaneous base, and then the screws or fixations can be passed through over the guide wire, and all the fixation and instrumentation of the spine can be done without opening the spine. And even the extensive scoliosis surgeries which we were doing before can be easily done with the smaller stab incisions, or just select the 3 areas where we can correct the entire extent surgery. The exact surgery is done the same surgery, but how you approach the spine is completely different. So other thing is the spine surgery safe? This is where a lot of people, why patients suffer with the pain and why they bear pain, because they don't wait for the toothache, and they don't wait for the urinary chloride, but they try to bear the back pain for long, basically because we work around the spinal cord, nerves. So surgery can result in kind of a neurological deficit is the main worry. But now we have a lot of technology, enabling technologies by which we can make the spine surgery very safe and simple. First thing to understand is cervical spine surgery and thoracic spine surgery is a cord level surgery, so we can make this surgery, theoretically, these are the ones which are potentially neurologically susceptible things, but any surgery below the L1, the spinal cord ends at L1, all the lumbar surgeries are not the spinal cord surgeries, they are root surgeries. Most of the things are quite safe, and now we have enabling technologies by which we can make this surgery very, very safe. We can have screws which are able to, we can put them under computer navigation percutaneously. So this is like a GPS mapping. We just record the, we will get a AP and lateral X-rays of the spine and feed it onto the computer. And this computer will guide you with the exact directions which you can go. This adds to the experience of the surgeon and the perfect positioning of the screws and safe position can be done. And during the surgery, we can now even monitor the spinal cord. We can monitor the BP, pulse, ECG, but you can't monitor the function of the nerves during surgery because the patient is anesthetized. But now we have a technology by which we can monitor the nerves also during surgery by doing a neuromonitoring, wherein small, I'll put it in a simple words, small amount of current can be put onto the skull and we can track the signals onto the foot. So any changes which are happening during procedure can be predicted or documented during surgery itself. Something like when you are reversing your car, something which is there in a 1 meter distance, it will give you alarms. So these things also will give you alarms. So the most recent advances, what we are doing now is awake spine surgeries. Patients who are anesthetically not fit, we can even do awake spine surgeries under local anesthesia. This is an extensive surgery. We can see we have done 4-level fixations with case fixation, all endoscopically without opening, and patient is awake and talking to us during entire surgery. So there are a lot of things which are happening, developing in the spine. There is all these advances are made to make the spine surgery safe, simple, to lead to early recovery. So this is the commonest cause of debility. Disability is the back pain. For visiting after knee pain, the back pain is the most common cause of consulting. And majority can be treated conservatively. Surgery is warranted to avoid deficits only, not for the regular back pains. And the recent advances make the spine surgery quite safe and simple. Thank you very much for your kind attention.
Thank you. It is a lucid and quite illustrative presentation. Now it is open for a question and answer session from the floor.
I would
Thank
like
you,
to welcome.
Sir.
This is recording because being you are an internationally famous spine surgeon, do you throw a light on recording the vertigo or ataxia in relation to this cervical spine problem?
Ataxia.
Ataxia.
Yeah.
Ataxia of any patient?
Yeah. I think what you are referring to is something called cervical myelopathy.
Cervical myelopathy.
Yeah, cervical.
Cervical reason for ataxia or cervical cause for?
So most common cause for cervicogenic ataxia, what we can call is
or vertigo.
Yeah, vertigo. Vertigo can arise from 2-3 ways. If the patient has got severe cervical spondylitis and there is osteophyte formations, these osteophytes can have some amount of compression onto the spinal cord, which can have a dynamic effect and leading to vertigo. Or if there is a vertebral artery stenosis due to osteophytes, they also can lead to vertigo. But most commonly, the patients say they are able to walk, their gait is becoming slow, and they are not steady. Those things comes with the cervical myelopathy. The best way, this cervical myelopathy is the disease of symptoms, not disease of signs. So we need to identify. Patient won't come with complaints that I have pain in the neck. So simplest way how we detect these patients is to do a rhombox test. The patient come with a back pain or knee pain, but he also have this kind of deficit. So we ask the patient to put legs together and close eyes, then they try to sway. Then we identify the patient with myelopathy. I think I have answered your question.
Thank you.
Thank you very much.
Sir.
Dr. Naresh, we have an exciting session on the pains. We now go on to the next session.
Yeah, the painful session is over.
Thank you.
I welcome other speakers, Dr. Harita ma'am and Dr. Vishweshwar Rao sir to join us, and Dr. Naresh Babu sir, please stay back with us. Chairpersons, please state speakers.
Request all the council members, office bearers of IMA state. Please go to hall. We are about to start council. Thank you.
Small announcement. A small announcement regarding the quiz. It's an online quiz. To participate in the quiz, you have to scan the QR code on the delegate tab. Once you scan the QR code, click on the quiz button. Questions will be displayed after each session for about 6 minutes. Click on the right answer and submit your quiz. 6 minutes. Then quiz winners will be awarded.
I request Chari sir to proceed with the introduction.
Good morning to all of you. And it's my privilege to introduce Professor B. Somaraju, who is an esteemed cardiologist from a combined state now in Hyderabad, having been dedicated his services to the treatment of cardiology problems for the past 46 years. Initially as a cardiologist, later became a researcher. He is a teacher to umpteen number of postgraduates and practicing cardiologist and a great philanthropist. Now his biodata or curriculum CV has been so much that if I read everything, it will take more than 20 minutes. And therefore, I will cut short with the salient points and present before you. He is born in 1948 and later he studied in Guntur Medical College as his post-graduation in MD in 1974, and he has completed his super specialty cardiology degree in Postgraduate Institute of Medical Education and Research in 1975. Here, I must say that I have been very fortunate to be associated with Professor Somaraj Garu as his roommate, which is a great honor to me. I was loitering in the lawns without having a room when I went there to study and join my PG in MCH. And Professor Somaraju has patted on my back, and he knew that I was not having the room, and he took me to his room and gave a provision to spend with him for 9 months. Thank you very much, sir, for your kind gesture. Now later on, he joined Nizam Institute of Medical Sciences as initially in Usmania Medical College and later NIMS as an additional professor and later director and dean of this prestigious institute. And here in this place, he is associated with writing chapters in various books and in clinical methods of cardiology and Brunwald's heart diseases. And then his research activities along with American universities and the Defense Scientific Laboratory has culminated in introduction of Kalam Raju stem. You must clap all of you should clap for his achievement. Here, he made a stent which is useful for the common man, which is cheaper and without any cost involved. Initially, the stent costed formidably. People could not afford it. With the introduction of Sir's stent, it has become a common introduction to the common and poor population. Thank you, sir, for your gesture. And then now, in later on, he introduced the coronary balloon catheter in 1998 for the first time into cardiology. And culminating all this research, activity, service, he was given Padma Shri Award in 2001 by Government of Andhrapradesh. Thank you very much, sir, for your achievement. And then he later on moved on from the care hospital in Hyderabad. Now he is presently employed, he is presently doing his a chairman of Care Institute of Health Sciences, and then moved on to the AIG Hospital, Gachibowli, as a chief cardiovascular scientist and as the head of the department of cardiology. He has in addition to the writing chapters and books in cardiology, he had many research projects, 8 awards to his credit.
Thank you.
So, thank you very much for your achievements, and over to Dr. Somaraj.
Good afternoon, good morning everybody, and thank you very much for asking me to share some of my thoughts with you, what I went through in life, and also give you some points of view, what problems we have today in the practice of medicine today and what we need to do. And some of those things that as enumerated by Dr. Chari as my achievements, I will tell you the secret of some of those achievements. The secret was I always surrounded myself with better people than myself. So that's was the reason why some of those things could be achieved, and including Dr. Kalam. Thank you. So having said that, the topic I chose today was to try to address you on, say, how do we manage ourselves in today's practice of medicine in 2024. There is, say, from the time we entered medical school in 1963 to now, enormous advances happened. A lot of things can be done to a lot of patients, and a lot of illnesses can be cured. Some of them can be cured, but a lot of them can be adequately treated, to the extent the lifespan of people enormously increased. So at the turn of the century, 1900, the average lifespan was 35 to 39 years. Now it's nearing 65 to 70 years even in India, and other places even more. Having said that, the technology is enormous and easily available everywhere. But the problem with technology is the technology overtook medicine. Technology overtook the clinical component or patient-centeredness of medicine. So in other words, we have become not patient-centered and became disease-centered. So to the extent that lot of specialists,